Hello everybody and welcome to the next session for DigiFest 2020. The next session is Essentials for Transforming Services that Link Patients Through a Digital Pathway. The session really will draw on the experience and the expertise and the learning from a number of Scottish speakers who have been involved particularly in developing remote health pathways and home and mobile health monitoring services. It's a great opportunity to listen to and learn from and join in the chat to ask questions of our speakers. We hope you will do that. The session is chaired by Morag Hearty, who is the Remote Health Pathways Lead for Technology-Enabled Care at Scottish Government. And Morag is joined by her colleague, Scott Henderson, also Remote Health Pathways Lead, and Helen Alexander, the Evaluation Manager for NHS Lanarkshire. Please use the chat, please ask your questions, and the session will be recorded and available to listen back on demand. I'll hand over to you, Morag.
Thank you. We seeing this all right?
Not yet, Morag. You screen share it? There we go. Perfect.
Yep. Thank you. Apologies, folks. The second go this morning of this, and yep, this is technology at its best. So good morning and thank you for the welcome, Nessa. We're really delighted to be here, and we'd really like to tell you about our journey through, as Nessa said, home and mobile health monitoring, but now really evolving into remote health pathways as quite a large programme across Scotland. So we'll talk about the foundations we've got for this. But we're not going to avoid the elephant in the room, which is the impact of COVID and the pandemic, and the impact, both negative and positive, that has had on our programme. So we'll be touching on some of that there. It will include our response to the pandemic, but a response to actually maintaining our services using digital. We're looking at the evaluation. That's key and crucial. It spans all of our work, and Helen will be telling you more about what we've been doing in that field as well. And finally, we will have a question and answers, but we'd really like you to consider some of the challenges and the considerations we're already having to face and think about, and we would welcome your views on that one as a final one. Thank you. The frame of reference for all of our work is really bedded within the tech programme in Scotland, and really what we're talking about this morning is sort of 3 or 4 different areas that come under that scope. The remote health monitoring we've already spoken about. There's a strategic procurement of a system that's ongoing. We have a pipeline of tests of change, and Scott will tell you more about that. But we're also linking very closely to the Modernising Patient Pathways Programme, MPPB, and asynchronous consultations there. Primary care have been key to a lot of our work, and there's work going on specifically in that sphere, in the digital asynchronous consultation systems. We're linking very closely, and even more so now, with unscheduled and urgent care, which has been going through its own redesign and has just recently moved into a different sphere altogether. And of course, our links with the Digital Health and Care Innovation Centre is key to a lot of the work we're carrying on with. I'm now going to hand over to Scott, who will tell you much more about the innovation pipeline and where we've come from at the moment. Thank you, Scott.
Oh, hello everyone. I'm getting quite a bad flicker there. Morag, have you stopped sharing?
I have.
Okay, I'm going to stop sharing again and try again. Hopefully this will come through. Well, that looks a lot better. Hopefully it's not as flickering as it was a moment ago. Okay, so thank you very much, Morag. To begin today's talk, I'm going to speak a little bit about the foundations of our work and the impact of COVID-19. This slide shows the first of those foundations, which is process. And the diagram shows that basically the tech development process, which is informed by the Scottish Government's digital health and care strategy, and of course our technology-enabled care programmes. It's a simple three-stage process that helps us to focus our actions and to prioritise our resources. Here we can see our pre-COVID programme, and you can see transforming local systems and test of change in that first column there. They are the formal entry points into our initiate and test stage. As initiatives show potential, then they are sort of promoted into the co-develop and promote stage. Scale-up blood pressure monitoring is a really good example of that, and I know that Morag is going to share more information about that with us later on. Initiatives that show or certainly the most successful initiatives then end up into our mainstream and scale stage. And to give an example there, Near Me is probably the most prominent example that I can give of that. Of course, Tech Programme isn't alone in having processes. Our colleagues in the Modernising Patient Pathways programme have their own approach. And as you can see on the right-hand side, they also support a whole range of different initiatives. I think the important point here is that you have a process and that you have that structure that allows the guidance of decisions. It would be remiss of me not to mention our colleagues at the Digital Health and Care Innovation Centre, who also have their own development process, which is very much predicated on a maturity model matrix, and again, very much fit for purpose for the jobs that they are doing. The second foundation is people, and in our programs we're blessed with really strong networks of very well informed people who are prepared to try new things, to go and make good things happen in their services, and to really stand up and make a difference. And a good example of the importance of this is with our test of change pipeline model. On the left-hand side here, you can see a whole range of organisations, and what we do is we typically put out a call for proposals, and without the type of response that we get from this whole range of organisations, people putting their hand up and saying, yes, I can make an improvement, none of this would work. The pipeline model here is worth a closer look because, of course, it's another example of process. What we start with is typically is with a problem, and it's got to be a worthwhile problem, a problem that if you solve it, it's going to make, an important difference. And what we do is we then test that through what we call proof of concept. And proof of concept is simply answering the question, can we bring together the people, the process, and the technology in the way that we thought we would, and does it work? And the way that that's tested is through improvement cycles, 3 30-day improvement cycles typically, PDSA. If a proof of concept does show value, or at least show that it's workable, we then promote that test of change into a proof of value. And we look to evidence value in 2 ways. The first is, can we scale that service up locally? Because proof of concept is a short period of time. Typically, you only get your first, few patients or citizen users onto the service. Can we really scale it up and start to get hundreds involved? And if that's possible locally, then that's a big step forward. We're also at that stage looking for value. So what difference is this new approach making? If that can then be replicated in other geographical areas and other services, then we know that we've got a really good candidate for scale up. And depending on the initiative, we then go through a third stage, which says, okay, what is it that we need to do now in order to either make this regional or national scale? Okay, the third foundation is having the right tools, especially to support spread and scale. So the remote health monitoring work provides a good example here. And much of the remote health monitoring work has been supported by a simple SMS service, which has been really helpful because it's allowed us to be able to create and iterate really quickly small service improvements, and some of those have had some really big impact. I guess our community of practice has been telling us for some time now that actually they're starting to outgrow that particular technology, and they need something else to be able to promote and accelerate the pace of change around spread and scale. Digital health is a very busy marketplace, and there are a growing range of, and actually a huge variety of niche solutions out there. And it's been really important to our community that, that we don't expect patients, clinicians or other citizens to actually have to work with a whole range of different products. So what we have specified is a solution that kind of consolidates the strengths from all the things that we've tried in the past, goes a long way to mitigating the weaknesses, and tries to consolidate all of that into a Once for Scotland solution that will allow us to remove some of the commercial and operational barriers that we experience, and at the same time give us the capacity and the flexibility to be able to take advantage of new initiatives that are coming down the stream. We actually went to market earlier this year with what we're calling our strategic procurement, and that's a procurement exercise that is in progress. So the foundations that I've just described were pretty much business as usual for the tech program up until about the end of March, and of course the COVID pandemic became a pandemic at that stage, and we had to hit the pause button, and literally all of our work was just put on hold for initially quite a short space of time, so that we could really focus on the immediate and very pressing need to mount a response. After a fairly brief period of reflection, given the work that we'd been doing over the past number of years, we were able to recognise how we could contribute to the wider COVID effort, and we were able to then reprioritise our work accordingly. Over the summer, it's actually allowed us the ability to sort of realign our activities so that we're still able to pursue our strategic objectives, but to be able to support the COVID recovery phase at the same time. One of the first things that we realised when COVID was announced as a pandemic was that that the tools that we had available to us were not really going to be able to do the job for us. They weren't really going to be fit for purpose in this sort of new environment. So we went back to first principles, which was what is the problem that we're trying to solve. And as the slide here shows, there's a fair proportion of COVID patients have what's known as silent hypoxia, and that presents in many cases a very grave risk of deterioration and much worse illness. At the same time, at the outset of the COVID outbreak, all routine services were suspended, and as we feared, there would be a significant backlog of demand for services created by that action, necessary though it was. In light of all of that, there was also a complete change in the way that people thought about service delivery, about the ways in which people were actually delivering services. So quite a complex problem. Our response to that was to come up with a specification that allowed us to go and find a tool or a set of tools that were highly configurable, because we didn't have a very hard specification about what it was that we needed to support. We also needed something that was going to be really flexible, because there were no service models really. None of that work had crystallized at that point. So we needed something that was going to be really flexible to allow us to be able to work with whatever emerged. And the third element there, multi-channel support, loud and clear from our earlier work that we needed to be able to make whatever it was that we're going to use as accessible to as many people as possible. So we were able to sort of pull all of that together really quickly. We went through a structured process that allowed us to go to market, find a suitable supplier, and to be able to bring that into operation really quickly. I guess since then, we've really had a great opportunity to sort of reorganise ourselves and understand the landscape better. With COVID cases falling over the summer, there was an opportunity to bring a bit more thought to this. Obviously, things are escalating again, but what we were able to do is to identify 3 key areas where we could really offer support. And the first, of course, is COVID services. And that was features around tele-COVID and the remote monitoring of patients with COVID-19 who are at risk of deterioration. And there are priority pathways as well. And you're going to learn a little bit more about those just shortly. The second pillar there is preserving innovation. And there was a lot of really good innovation work going on prior to COVID. And as some of you may well know, a lot of innovation work can be quite fragile in terms of it's got very specific funding periods, and that decisions need to be made about extending things in quite considered ways. And the procurement arrangements around those can sometimes be quite complex and convoluted. However, through our sort of reorganised work, we were able to identify a few really good programmes that we're now able to continue to support. First of these is a programme called Dynamic Scot, which is a really innovative approach to remote managing COPD patients, and it's showing tremendous potential. The second is a process of dermatology, whereby patients can send images of whatever it is on their skin that they need to share directly with their dermatologist, and without having to go in for an appointment. It helps to pre-qualify that, and that's currently being scaled up across Scotland. And the third was an emerging piece of work around taking video clips, and this was for people with neurological conditions, and it allows their families and people who are close to them to take short video clips of a neurological event, i.e. a fit, and to be able to send that into the specialists directly for assessment. And again, that's being scaled up right now. Huge benefits from that approach. So preserving innovation, there are a number of other innovations in the pipeline that again could benefit from similar treatment. The third pillar there is around emerging needs, and what we're continuing to learn about COVID and sort of the changing dynamic around that is that the phenomenon of long COVID is pretty serious and is likely to be around for quite some time. So we're currently reviewing our options around how do we support people with long COVID. Similarly, GP practices and their working practices have been changed quite significantly, and we are investigating digital tools to support the digital triage for GPs. So with all of that change, I guess we've reorganised our approach, and we're now calling ourselves Remote Health Pathways. And it's really a collaboration of programmes and projects, some of which were pre-existing, some of which are new. You can see some of those described on the right-hand side. I'm not going to go into the detail. But what I can say is that, that this new approach, the sum of the parts is very much greater than, the sum of the parts is much greater than, or the sum is greater than the whole of the sum of the parts is better than each part individually. And we've really seen a coming together of people across government, across different programmes of work, and it's been really encouraging and really beneficial, really learning an awful lot. And it's really accelerated the work that we've been involved with. Now, of course, we've not abandoned our foundations. So this last slide here is really just to say that each of those initiatives that described on the slide before, they all fall into our process. And with that, I think I'll hand you back to Morag to take us into a little bit more detail.
Scott, have you finished sharing?
Oh, sorry.
Thank you. Okay, so thank you. So Remote Health Pathways rebadged from HIM, as some of you may remember, which was Home and Mobile Health Monitoring. So really just to sort of say that the aim of Remote Health Pathways and remote monitoring was to provide people with a safe and effective solution for their health condition management, and we engage with our partners across health and social care partnerships and all our stakeholders. It was also mentioned in the programme for government this year in September, saying that we would be doing some digital monitoring to aid people in with a diagnosis or the longer term effects of COVID-19. So this is here for the long haul. It's not just something that was an immediate knee-jerk reaction. We absolutely, as we've come across in the last few months, we're beginning to realise how much our previous work actually can inform and take us forward into a new world, as I think we're all realising we've have coming forward. So key principles here, you've heard what Scott's saying, but let's break it down a little bit. Keep it simple. So we said, we know there's lots of wonderful things out there, but however, we needed to think of something that was simple to use, and keeping it simple there was a key message. We absolutely had to focus on the COVID-19, not just about the response to that, but the recovery and the ongoing impact this was having on many of our services for the public. We're guided by national and the local priorities. We went out to local board areas and asked them what their emerging priorities were at that time. And that's a changing landscape as well, as services are standing up, different restrictions are coming in, and different emerging issues are coming forward, but not least the fact that staff culture and our citizen culture is changing. So as people are using digital technology, they're realising, oh, we could also do this, and oh, what about doing that? So definitely there. However, I go back to what Scott said earlier, we're looking at the problem first, technology second. So there's no point in just plugging in technology willy-nilly. We need to know about the people are going to use it, the people are going to receive it, and how then technology can make the difference. And Helen will tell you more about so what. Collaboration, co-design, shared learning, all buzzwords, but absolutely, we've been able to show that we've used the opportunities of the pandemic and the responses to actually increase our co-design and the learning absolutely massively, as I'm sure many people across the world have found just something different going on here. The engagement and support has been absolutely magnificent. I can't thank people highly enough. And I know that Scott did give you a bit of an overview of who else has been involved here. But to redesign and implement any new pathway and any new services, we started off with the clinical advisory groups. These were new to us in Remote Health Pathways. We stood them up with clinical leads, but not only the clinicians and the key people that had to be delivering it, but bringing in the patients and the patient experience as well there, what was going to be best for them. As Scott's already said, the Modern Outpatients Programme, Modern Pathways Programme helped facilitate those groups and have been key to actually making sure we were linked in with the right stakeholders. We've also had support from NES, our National Education in Scotland, who have been supporting us to develop the training, which we'll be putting nationally, but certainly, and designing the information leaflets and the training materials and the information for staff as well as patients there. Primary care, as you might expect, and the COVID leads, we engaged with them. We want to know what's happening, what's going to be the best support for them. If we're going to implement a pathway, how's this going to help them? And certainly they have come back with their priorities as well, and what's doable, what's actually practical on the ground. Our NSS and eHealth colleagues, right from the very start, it's not really been mentioned very much. There's no point in having a system if it doesn't integrate. And we absolutely, this is one of the key requirements of or any new procurement, was that it had to easily integrate with our existing systems. And in Scotland, that's no mean feat. We have many systems and we have many requirements, but we're getting there slowly, and certainly we're beginning to see the light in integration with a lot of the work we're having with other partners. And of course, let's not forget the industry partners that have come on board, supported sometimes with the Digital Innovation Centre, but certainly, coming in with their ideas and listening to what we wanted, what we needed, not just coming with a ready-made solution, and actually taking on board a lot of design principles and feedback to improve what the offering would be there. So, many thanks to everyone here. So it wasn't just a bit about sharing and moving it. It was really building those blocks and starting to get something that was fit for purpose. Tele-COVID, you've already heard a little bit, and Scott spoke about this. So in a very brief, this was our first key priority we had to look at. As Scott's already said, most people are sent home with a diagnosis of COVID-19 to self-manage, and they get better or start to feel better relatively quickly. For some, that's not the case, and we also knew from emerging evidence across the world that the early detection of worsening, which could happen very, very rapidly, was absolutely key to making sure that there was a good clinical outcome for that person. And the faster we could actually get them plugged into some extra advice or get them into hospital where that was appropriate, then the better the outcome was likely to be for them. So the system we're using, very simply, it's a remote server, but key to all of what Scott said already was we can monitor this on a version, on an app, using the internet online, using the simple text messaging if that's best, or indeed a touch tone phone for people who might either have dexterity, visual, or other issues that might make that a better option for them. So really trying to be as inclusive, and if anyone heard some of the conversations been going on last week and indeed this morning with our keynote speaker, talking about inclusion of digital and actually making sure we had something that was fit for as many people as we could possibly manage, and taking on board all of those lessons. It's not perfect, we wouldn't suggest it was, however, we're making a great improvement towards that. Contacts are given, the patient can have a follow-up with a clinician if that's required, or indeed just go on and self-manage with some advice that's been given around just some simple advice. But we also, we're aware that technology does feel it, and it might not be the technology, it might actually be the pulse oximeter we give them, or their internet goes down or something very simple. So we give them a written management plan just to make sure we've got that belt and braces there for them. And I think that's only just being sensible. It's not saying that something's not going to work, but let's just make sure everything's right there. Blood pressure monitoring in primary care. This was a programme that started last year, well before COVID, with some success. And just to put a background in that one, and going back to this, why are we doing it, and why did we think we had to do it? 30% of Scotland adults have high blood pressure. We've got a good number of that, but only just over 25%, 27%, a quarter of them will actually have that blood pressure managed. And if it's not managed, then it can lead to significant other issues, including heart disease and stroke. 1.2 million appointments last year before COVID were actually being spent on just somebody coming to our practice and having their blood pressure monitored. So we really knew about the pressures on our primary care colleagues. We had to do something about that and offer an option, but not only just for the staffing, for the patients as well. We had to think about how could we make this more accessible for our patients as well. So scale up blood pressure. We definitely wanted to accelerate and use the adoption of that time of home health monitoring across primary care. The intention is to reach a further 20,000 citizens, and that's looks likely to be back on track, despite some months in the middle of the summer at the start of pandemic, when long-term monitoring of blood pressure was not exactly on everybody's first thought. However, we're beginning to reinvigorate that now, and we wanted to at least have 50% of our primary care. So not high expectations, but let's make a start to actually scaling this up. And I think this was a good example of how something started with a very small test of change in respect of the Western Islands with one GP, moved to Lothian and Lanarkshire and Ayrshire, where we were able to do it as a test of change. We very quickly scaled it up to quite significant levels. The really great outcomes of this was that patient experience and our citizen experience, saying this is so much better. They were reducing travelling costs, we were providing more convenient access to the service, we were raising awareness and optimising the management of their blood pressure. But of course, as soon as pandemic hit us, one of the key benefits that came in was that reduced exposure to infection. Now, a year ago we would not have thought anything like that, but certainly that's been a key to scaling this up now. The COVID priority pathways, as Scott's already said to you, we went out to the partners, we went out to our boards, we engaged with a number of different stakeholders and asked, what are the priorities we need to look at? And as I've said already, COVID-19 and the response and recovery was certainly there at the top of the list. However, closely followed by some of our long-term and chronic disease management, heart failure, COPD, chronic obstructive airways disease, asthma, all these things that are usually managed in GP practice for the main, but with specialist nurses and specialist services taking the more vulnerable of those people. Perioperative, where people used to come for quite a long appointment before they had surgery. Was there something we could do digitally here? And we also used the scale up blood pressure, into a new platform for areas that didn't have it already, and the maternity services that had already at the start, where pregnant ladies in Scotland were being shielded, so they were being asked not to attend appointments if they absolutely didn't have to. They still had to have appointments, but with the use of VC and some remote monitoring for blood pressure and urinalysis, then that was saving some appointments there. Phase 2, we've already made a start, and I should actually go back and say in phase 1, all of these pathways are really under almost near to finalisation, and they'll be starting to roll out very, very shortly, if not in the next week or two. In phase 2, we've already started conversations. These were coming out of discussions with our different care groups around chronic pain management, some cancer pathways, musculoskeletal triage, the pulmonary and cardiac rehabilitation, which also, of course, could be impacted by COVID-19's own rehabilitation, that long COVID that was mentioned before. And as I said earlier, as we talk to both patient groups and the clinicians, we keep hearing, we could be doing this. If we did that, then we can do something else. And I should say this is across both our primary care services and our secondary care. Pre-existing pathways were already on the system that we procured for irritable bowel syndrome and undernutrition, and that's from our dietetic colleagues. And those were already starting to roll out in other areas as well. So that's already underway there. It's been a huge undertaking. We look forward to it, and it's certainly giving us a great deal of good baseline for the strategic procurement that Scott's mentioned earlier. So we know so much more than we did at the start of this year. I'm sure everybody would agree. So I'm going to hand over now to Helen Alexander, who's the planning or evaluation manager in Lanarkshire. But Helen also has had a great deal of influence and support given to the techno programme. So thank you, Helen.
Hello everyone and welcome. Even though I'm employed by NHS Lanarkshire, this work is national evaluation work, and I would just like to say that it's been really heartening so far during DigiFest to hear so many people talking about the outcomes of all of the technology-enabled care work and all the digital work. But we can't just keep talking about it if we don't measure how we're doing in terms of achieving the outcomes. Then they remain nothing other than words. So we have to do a little bit of evaluation, which isn't everybody's favourite topic, but I couldn't be more enthusiastic about evaluation if I tried. So I just wanted to say that The way that we're looking at the evaluation of the remote health pathway work is as an evolution. We started way back in the mid, about 2014, 2015, looking at what we called in those days home and mobile health monitoring. And that was at an early stage, as Scott has described in the evolution of the journey, where we had many partners looking at many different pathways. But through that work, we were able to gather evidence of a lot of outcomes that we were able to say that the digital solutions had actually contributed to the achievement of, that they wouldn't have been anything like if they'd been left to be otherwise. And I'll explain a bit more about that in a minute.
Sorry, Helen, I think you're sharing the presentation view of your slides.
Okay, how do I change that?
If you just unshare and reshare, thank you. Just we weren't seeing your whole slide.
Do I do? Share. Is that any better?
Perfect, thank you.
Sorry about that. You haven't missed much so far. The Scale Up BP is the next stage in the evolution of the evaluation, where at this stage we were able to say, even though we're continuing with many partners, this is where we were looking to scale up one national pathway for high blood pressure, even though the pathway's in 3 parts for diagnosis, medication titration, and then long-term monitoring. At this stage, we were able to look at fewer outcomes because of the vast amount of evidence that we had already collected through the home and mobile health monitoring evaluation. And now we've moved into the emergency procurement with the in-healthcare solution, where there are going to be, again, many partners. And as Morag's just described, a series of core national pathways, and we're still learning from this. And now I'm not able to move it forward because I'm on the wrong. That's better. So a little bit about each of those 3 stages of the evaluation journey. The home and mobile health monitoring back in 2015 to 18 was the first theory-based evaluation that we had done in the tech programme in Scotland, and we used an approach called contribution analysis. I'll say a little bit more about that on the next slide. But as I've said already, what we were able to do there was generate considerable evidence of the outcomes that that programme was achieving. At that time, we also looked at an early version of work from Trish Greenhalgh in Oxford, which was looking at that NAS acronym stands for the non-adoption and abandonment of technology and challenges with scale-up, spread and sustainability. And that allowed us to look at, from an evaluation perspective, at a structured approach to scale-up, spread and sustainability. And while the evaluation wasn't essential to the plans for moving into the next phase for Scale Up BP, very definitely the results resonate with the next phase when we moved into the one programme in Scale Up BP. So the national evaluation of Scale Up BP, we're writing an interim evaluation report just now, and we've used a new part of the NAS, which is a complexity assessment tool. And we did a brief report of that back in March 2020, and then we know exactly what happened back in March 2020. But so far with the Scale Up BP programme, what we know, and Morag has kind of alluded to that, is that we already have, as of last Friday, 13,630 of the 20,000 target recruited, and we have 426 of the general practices in Scotland recruited to the programme as well. I think there are about 1,000 GP practices, so we're getting close to halfway, and we're more than halfway through the recruitment. The recruitment itself, Morag was suggesting, we're beginning to get back on track with that. We're actually doing better than we were doing before that COVID hit. So we had a rate of about 500 a month recruitment before March 2020 and the months preceding the COVID-19. We're currently in the last few months looking at about 1,000 recruitment per month. So we're actually doing better at the moment, which hopefully will get us back on track for the 20,000 target. And some of the partners have already achieved the target. When we move into the next phase, so we're going to be evaluating the current emergency procurement of in-healthcare, and we've agreed we'll use the same methodology. We will want a variety of data to look at outcome achievement, But what we have been able to build in this time is a standard feedback questionnaire for the people using the system. And it's very definitely based on all that we've learned previously through the first two programmes. So we know what to ask people, we know what, generally speaking, up until now has concerned people, and those are the things that we use to structure the questionnaire. Very briefly about the contribution analysis approach that we use for this. So we set up a theory, and then we say, can we gather evidence that would show that our theory is effective in achieving the outcomes that we've set ourselves? We're not looking at cause and effect here. This is not randomised controlled trial territory. This is the real life of how we see whether or not we are achieving the outcomes that we want to from these programmes. We use qualitative and quantitative data, and interestingly for technology-enabled care, the use of video clips as evidence for some of this evaluation work has been absolutely vital. And you can see in the little bubbles down the right-hand side of this slide, it really speaks volumes when we actually report what people have said about the technology that they've used. So the first one there, somebody's mentioning that they actually feel like the clinicians and the people that are looking after their health or helping them to look after their health are actually with them there and looking after them. It makes them feel that they're not on their own doing this remote monitoring, that actually somebody is there working with them. The second one, I think, speaks volumes about self-management. So somebody's saying that I made the changes to my diet to help get my blood pressure down. That is, to me, a shift in who's responsible for maintaining my blood pressure and my condition control. That's about somebody who took on the remote monitoring and realised when they hadn't previously that they had a contribution to make to this to maintain their blood pressure at the right level. And the bottom quote there is somebody saying just they felt really reassured to know that everything was going well with their readings. They weren't waiting to go back to a clinician to say, yes, you're all right. They actually knew what their own levels should be, and they felt reassured that they knew what they were. So in terms of the evidence that we use for the evaluation, the only thing, while we can have a variety of evidence, the only thing that we require is that it must be robust evidence. We don't take substandard evidence at all. And by that we mean that it meets the generally accepted standards for the type of evidence that it is. So for example, if it's numbers, we'd want to be assured that it was a reasonable sample size. If it's words and qualitative data, we wouldn't want anybody to have asked any biased questions, and we want to be comforted that the analysis of the qualitative data was done well and properly. So just as examples, that it needs to be robust evidence. The other thing that we can do with contribution analysis, which I find reassuring, is that we can become more confident that the outcomes that we're claiming we're making a contribution to, we can be even more confident in that because we start to look at what else might be impacting on the results. I don't think there's many outcomes that we can say it's one particular thing that is leading to that outcome, which is why we're not claiming cause and effect here. But there could be lots of other things that are impacting on an outcome. And for example, the rates of smoking in Scotland, there are teams all over Scotland looking to support people to give up smoking. But at the same, a few years ago, Scotland introduced a smoking ban, and there's been the development of e-cigarettes. So there's lots of other things that can help people to stop smoking. So for a service to claim that they're the only person, the only thing that's made a contribution to that outcome, it doesn't stand up, because there's always other things that can contribute to that. So part of the methodology that we use is to look at what else might be explaining the results that we're claiming the remote monitoring has led to. And we went through quite an elegant process of doing that for the home and mobile health monitoring first report that we did, and we'll be continuing with that. But it's just to take account of something else might be contributing to the results that we're claiming. But if we get to the stage where we can tell a story about achieving the outcomes that supports the theory of change that we set up in the first place, we can be reasonably confident it's the remote health monitoring that's done that. And we know that with that middle quote there, where somebody says, I realised it's up to me to be self-managing my own condition. We know that it's remote health monitoring that led to that, because this was a person who was just not doing this before. So we can be quite confident that it's the technology that has helped them to do that, where they didn't have the opportunity before. So if we don't get the right data back for the evaluation, then our theory of change may not be supported, and we may have to change it, we may have to think again. In one of the previous slides, I said we've been able to evolve the outcomes that we're looking at in terms of the evaluation. So The first column there about the home and mobile health monitoring report back in 2018. We have a huge long list of outcomes that we were able to gather data of a contribution to. So when it came to the scale up BP, where there's a cross in that column, that means we decided we weren't going to look at that outcome this time round. We were going to focus our efforts on the things that we felt we really needed to be quite sure of. So there's no point in evaluating scale up BP if it doesn't help people to reduce their blood pressure and improve their condition control. There's no point in using remote technology if it doesn't help us to reduce the number of times that somebody has to come in for a service. These days, we always need to look at the use of resources and the assumption that digital technologies are always more resource efficient. They may or may not be, and we wouldn't want to be using technology that people didn't have a positive experience of using. And what that also meant in the evolution was when we come to the current in healthcare evaluation, the pathways that Morag described, again, we can reduce the number of outcomes that we focus on here. And the three in red are the three that we think we really should prioritise this time, even though we haven't fully bottomed out. We've still got some question marks over some of the outcomes. We need to be looking at the use of resources and people having positive experiences of using this technology. And our standard questionnaire will help us get some of that feedback. But this time, and I think Morag slightly alluded to it, we have the opportunity to look at some aspects of digital exclusion this time with the reduced health inequalities outcome. So if people are able to engage with the remote monitoring through a number of different channels, then that helps, as by definition, be a bit more inclusive. And it might be that if you have a landline but you don't have any data for your mobile phone, then you can engage through the landline. And Morag obviously mentioned that not everybody does have all of these technologies, but the more channels that we have this time, the more chance there is of including more people. My last slide is just to say, where do we move on from here? It's unlikely that the outcomes are going to change much as we move forward, although if we do, then we can certainly accommodate that within the method, because contribution analysis is flexible enough to let us do that. We can always tailor the data gathering to suit the different technologies, the partners and conditions. And a huge hats off to the partners who have submitted data for all the evaluations and will continue to do so as we move forward. It's been a huge amount of effort for all the partners to make sure that they get enough evidence submitted to show the difference that they're making. Timescales and plans, as both Scott and Morag have mentioned, as we know from 2020, can very definitely be affected by external events, and we just have to move forward as best we can. But no matter what happens next, we need to keep generating evidence, because as I say, there's no point in talking about outcomes if we don't gather the evidence to demonstrate that we're achieving them. So I'll leave it there.
Thank you, Helen. That's really interesting, as we always will be from yourselves. Ladies and gentlemen taking part in this, we have a few observations, as I said, that we would consider. But first of all, I'll go back to some questions that are there. And I think Helen and Scott, perhaps you would be, Helen in particular, I think, to answer this first question for the speaker, asking about, do you feel that staff in different parts of the health and care system are really aware of the potential for remote health monitoring? You've been engaging there with a number of our partners. What's your thoughts on that?
I think it's getting a lot better than it was. I think the more people hear about it and the more people know the benefits about what the outcomes that can actually achieve, then I think we are, converts is probably not the right word, but I think we're winning friends the more we expand. But I think there are probably still huge pockets of our sector that, whether they don't want to know or they don't realise the potential, I think there's a lot more work to be done. But the more we can do about spreading the word and demonstrating the success and the challenges, let's not be shy about saying there's more work to be done. I think Scott was quite clear about that in his presentation. But I'm quite convinced that there are, I don't know who they are, but I'm quite convinced there are still people out there that we still have to reach.
I think you're absolutely right. And I think, Scott, you might want to come in here, and some of the information we've been coming, I think it's been a little bit, my own feeling has been, there's a little bit of the chicken and egg. We didn't want to really spread this out until we knew we had a solution that could answer a lot of the questions and raise expectations unrealistically. So, Scott, I don't know if you want to say more than that.
Yeah, I mean, I think I don't want to talk about COVID-19 and positive effects, right? I don't want to be disrespectful in that way, but one of the ways in which COVID has changed things is that it has made health and care colleagues more receptive to our messages around what remote health monitoring can do. I think it's, in all our roles, we're bombarded with messages every day about a variety of things, and we have to pick out from that the things that are going to be immediately useful to us, and we have to be very selective with our attention. And I think the environment that we're in means that what remote health monitoring can offer now is much more of use to a much wider range of clinical colleagues.
I would also say that programmes like the Connecting Scotland programme, where they're addressing the digital exclusion, is actually letting the public be more aware as well. And certainly we've seen patient power, if you will, where patients have asked, why am I having to come into a surgery? Why am I having to take time off my work? So that's beginning to be more prevalent as well. The next question was about learning from the local deployment for shared more with the national leads. Is this working well? I would say that we've had a history in the last number of years with a network in Scotland about remote monitoring, or the home health monitoring network. And that's been a very close group who continue to network and keep in touch and share their learning and share their experience and share documents, and absolutely been very freely given of their time. Helen, again, you've had this links with the local deployments, and it's not just about blood pressure, it's about the whole remote monitoring. Certainly, I know there's one or two people on the call that as participants today who've been involved in that network. Would you agree?
Definitely. I mean, I couldn't write any evaluation up if it wasn't for the amount of working together and sharing that we've managed to achieve. And, I pay tribute to all the people out there who are working their socks off to try and get the systems implemented locally. And then I rock in behind them and say, by the way, could you give me all your data to make sure we can demonstrate the success of this? So it's been tremendous. But it isn't just partners in the local areas. It's everybody that you had in that slide with the people in the middle in the big circle going round. It's humbling to an extent to just contact people to ask them something, and I don't think I've been refused anything yet. It's really quite remarkable. So I think the response we're getting and the collegiality that we've developed in technology-enabled care is one of the most pleasing aspects of doing this kind of work. That and the fact that people keep letting me evaluate things, because it's never top of anybody's list. And I think it's great that Scotland has put its money where its mouth is to say we really need to be demonstrating the success of this.
Absolutely. I take my hat off, because I say we've always been seen as having a strong network of people across the piece there. So definitely. And I see someone saying there, couldn't do it without your support, Helen, thank you. And I would absolutely endorse that one full-heartedly. So we've brought up some questions that we know that are key. As I say, we've already spoken about inclusion and accessibility, a key theme across the sessions recently. How do we make that better? How do we make sure we are inclusive? We need a problem-led service redesign, and moving from that, we'll just do it remotely, to actually what's that value proposition that Scott spoke about, supporting scale for multiple initiatives. So our programme has gone from being one or two things really sitting there that we were sort of supporting, to multiple initiatives coming through, and we want to keep that happening. So how do we manage that? Targeting the innovation, how do we actually make sure we get something together, something that's actually helping innovation and embracing it? And how do we manage the demand? Not having unrealistic expectations in this. We'll try and do that. But most importantly, how do we sustain it? There's been a lot of funding available recently, at the moment due to pandemic. However, we also know that local areas and everywhere else will be perhaps constrained in months to come. how can we make this a value and make it sustainable going forward once some of the the things settle back down to normal. Scott, I don't know if you want to say any more on that one.
No, other than that, I guess we find ourselves in a position where we're going from at level A, and there's a big jump to level B in terms of interest and people wanting to do things. It's really busy environment. So being able to work collaboratively becomes difficult when there's so much noise in the system, and we have to work really hard to make sure that we make sure that that we have positive outcomes no matter what in those circumstances. Yeah, I mean it's I guess the phrase is growing pains, and how do we get through those growing pains in as painless a way as possible, if that is possible.
I think a last question really about complex health and care systems bespoke to each region or country, and what can we really take from other countries and regions learning and outcomes. And certainly, thank you, Nessa, for that one. As you know, Scotland, we have brought this programme for the last week and next few days across the world. We've got a really good network that's actually helping us learn from other areas, and in particular, most recently, probably was some of the learning that we've shared with as far away as the colleagues in the USA and New Zealand and Canada, where we've shared our pandemic experiences, but also how we've been working to stand up our regular services as well. And there is always something that we can learn and share. Sometimes we learn with quite envious of some of the systems, particularly I think when it comes to integration and being able to share records is probably way ahead of what we've currently got. However, we'll get there eventually, and I think we're starting to see the light at the end of the tunnel. Nessa, I don't know if you want to come in with anything yourself on that one. He's not there.
Oh, here she comes.
Sorry, Nessa, I put you on the spot there.
No, that's all right. Sorry, I just had to come back in, as it were, rather than just add a question to the chat. I think it's really interesting because from my perspective, I would say this. It's fantastic to have the opportunity to learn from other regions and other countries, whether that's in the UK or as you say, New Zealand or anywhere else. But I do wonder, listening to Helen talking about the evaluation, I suppose my observation was more about, given how complex individual health and care systems are anywhere in the world, how can we really take the learning or generalized findings from other projects, other implementations? Does it really help us? That's probably too big a question for this stage in the session. Does it help us in part? Can it really inform how we develop, or is it more a case of learning what not to do? I don't know.
I think a bit of both, Nessa. I think from my point of view, yep, we can learn, well, okay, that's not, I know from some recent examples that we said, okay, I don't think we really want to do that. I think we can do it better. But there's other areas where it really opens our minds to what the possibilities are. And I think it is about that blue sky thinking, all the cliches you like around saying, actually, wow, we couldn't have thought that would be possible. And yet we've seen some absolutely outstanding changes made in other countries, and we can certainly take that learning and try and at least take part of it there. Has anyone else got anything? Helen, Scott, do you want to add anything else before we close down?
No, just to really support what you'd said there about knowledge exchange, and it really is about knowledge exchange. It's been a huge part of our programme to date, and I don't see that changing anytime soon. That whole piece about learning what not to do that Nessa mentioned is every bit as valuable, both for us, but also to share that with others. And I think through our network, we've been quite successful in creating an environment where working out what doesn't work is just as valuable as working out what does, and we're not ashamed to share those things. And I value that tremendously, and I think our partners do as well.
And I think the only way to do that is by sharing and talking, because this isn't the kind of stuff that gets into peer-reviewed journals. Evaluation doesn't really get that kind of headline. So gathering the data to demonstrate the success, I put money on it that aren't that many people champing at the bit to be reading that. So A, it's not readily shared, and B, it's not something that people get very enthusiastic about unless you're me. So the only way to share these experiences is to talk about them in forums like this and within our own networks. And we can learn a huge amount internationally. I mean, the outcomes don't change, but the context and the way we go about it are always very different.
Yeah, thanks, Helen. So it just leaves me to say thank you very, very much to everyone that's participated and everyone that's spoken today. Couldn't have done it without you. Certainly couldn't have done it without the support of Nessa and the team in the background, keeping us right. And indeed to all the participants and those who will actually be perhaps watching this at a later date. Please do get in touch with us. We're more than happy, as Scott's just said there, we're happy to share it, warts and all. So thank you very much indeed, and please do go and see some of the other expo, the posters and everything else that's going on around in this digital world. So thank you so very much again, folks, and have a good afternoon. Bye.